Okay, so this is a young boy. He had been following up with me for the last 15 years when he was first 21, and he came to me with grand mal fits and occasional myoclonic jerks. And his mentation was normal, and I thought it was routine juvenile myoclonic epilepsy, though there was no family history of epilepsy. And now he came to me again as a routine follow-up. He had been following up for actually 15 years. And now 1 year, he started getting slurring of speech and imbalance while walking. And on examination, he had typical cerebellar dysarthria. He had gaze-evoked nystagmus, finger-nose ataxia, gaze ataxia, and his reflexes were absent, reduced vibration at the toes. So this was his MRI. And MRI showed this peculiar lesion in the middle cerebral peduncle and cerebellum. Anybody wants to say anything at this point? So myoclonic epilepsy, occasional grand mal fits, 15 years, non-consanguineous marriage, and now he's come with a 1 year history of cerebellar ataxia with these lesions. So anyway, I thought probably this is a progressive myoclonic epilepsy now. We are no longer dealing with obviously IgE. It is not juvenile myoclonic epilepsy. There was cerebellar ataxia and his MRI was also abnormal. And
cognition was normal.
Cognition was normal.
PME would have cognition impairment.
Which one? Sorry?
All PMEs generally have cognition impairment.
Progressive. No.
Yeah, but he had cerebellar, so he's not IgE by any means now. But cognition is not absolutely necessary that it has to.
Yeah, he falls into the PMA-PME overlap, no?
Yes, yes.
So, and you can have some which don't have cognitive problems, such as Unvrik Lundborg doesn't have cognitive problems in a big way.
What is PMA?
PMA is progressive myoclonic ataxia syndromes.
Okay.
So like all your famous 5, Unvrik Lundborg, mitochondrial sallodosis, Lafora body disease, they all come under the PMA, but they can also have some epilepsy, mitochondrial, all of these come under.
Yeah, this guy peculiar, 15 years, he looked just like a routine epilepsy, just like myoclonic epilepsy, juvenile. And then now 1 year he started getting this.
So Unvrik Lundborg, for example, can have that sort of a picture for a long time before they get the ataxia and so on. And also depends on what sort of myoclonus if you're going to show us. What sort of myoclonus is it? Is it cortical, not cortical? And
no,
so
it was just looking like juvenile myoclonic, just bilateral. I don't have a picture of the myoclonus.
It wasn't reflexogenic.
But it was not focal cortical unit. It was just bilateral hands. So it looked exactly like juvenile myoclonic.
The family history was negative.
Okay, Kailash, what about the MRI scan? You saw the MRI,
I mean, we've only seen one bit of the MRI. I just want to know whether the basal ganglia and the brainstem is okay. Is it this appearance is only in the cerebellum, or you got some other areas which are involved?
Only cerebellum. No, nothing else was abnormal.
And is not on any particular drugs?
No. So I thought of metronidazole and things.
Yeah, exactly.
Not on any drug. No.
Yeah.
But this image is non-specific. A lot of things can cause, I mean, apart from metronidazole, many other things can cause this dentate bilateral.
So, yeah, variety of the CTX, for example, can give you this metronidazole. There's a whole paper about all these conditions, which I can never remember all of them.
Okay.
Mitochondrial epilepsies can also have, I think, some of them.
Yes. So, I mean, there was no negative myoclonus in him, which we might sometimes may get in the progressive myoclonic epilepsies. He had mental function can be affected, neuropathy may be there, myopathy may be there. But he had essentially evidence of neuropathy. His reflexes were absent.
Were myoclonus early morning or seizures type for early morning? You know, in JME classically.
Yes. No, it was not early morning.
Yes.
Sir, any tendon xanthomas for CTX?
No.
Because JME, if you do, is a very classically, somebody would have early morning myoclonics and then seizures. That would be like JME. if you have seizures at a point of time, myoclonus all the time, that will tell you from beginning that it's not JME.
But we get JMEs with myoclonus in the daytime and not necessarily always on waking up. I mean,
Mostly at post-awakening. That's classic.
Yes.
Yes.
So I thought of the whole DD, the typical whatever Kailash said just now, Olveric Lundborg,
Yes.
lipoacidosis, mitochondrial, and biotin. Most of them are autosomal recessive, rarely autosomal dominant or majority are recessive. But he was born of a non-consanguineous marriage, so I think the recessive ones got probably away. So you have to be careful of these guys presenting as JME, particularly Eric Lundborg and Lafora can start at adolescence, and you have to be suspicious if clinically it's refractory or the EEG is atypical, or like when I just said, if the myoclonus is not classic early morning, or if you get negative myoclonus. And sometimes only on follow-up, like in this patient, we got cerebellar signs and luckily no cognitive decline as of now. So there's another sign. When I was checking his eyes, it looked funny. So I did his head impulse testing, and he had bilateral head impulses positive. Unfortunately, the video I've edited to make it very short, but you can see that it's bilateral. Can you all see bilateral head impulse?
Not really.
Not really.
Okay, so
It's sort of frozen.
yeah, this see there. I just
It's
played.
not moving here, sir.
It's a frozen head impulse.
That's the problem with Zoom. It's probably the internet connection is not good. But anyway, you can take my word for it. He had bilateral head impulse positive, and he had no hearing loss, nothing else, but the head impulses were positive. And now, what is?
So he had a neuropathy. Canvas is top of the list then.
Yeah. So there are various things, and now that you have bilateral
And Sando also.
vestibulopathy,
Canvas.
you need to think of canvas. So yeah, I did think this is cerebellar ataxia with neuropathy and vestibular areflexy syndrome. He had cerebellar, he had vestibular, and he had a sensory motor neuropathy. And typically in canvas, the pathologic genes are not yet really identified. They are
No, it's identified.
Yes. So now, in my patient, I sent his genetic thing, and he had a Paul G mutation. So he was a mitochondrial myopathy.
Yeah.
Paul G. And it can present with myoclonic epilepsy, myopathy, sensory ataxia, or what is called MEMSA. It can present as Sando or sensory ataxia, neuropathy, dysarthria, and ophthalmoplegia, or it can present as just progressive external ophthalmoplegia. But in our patient, he came with a syndrome looking like canvas. So I couldn't find any reference anywhere of Paul G having shown to look like canvas. I looked up the rare diseases, etc.
I would still do his mutation for canvas.
I sent his whole thing.
No. But this has just been described in the last 6 months.
Okay. I'll.
So the guy who has found it is at Queen Square.
Okay.
And it's a very peculiar type of gene. So you will not pick it up on your normal panels or sequencing. I can look it up and tell you in a minute.
Okay, let me know, and I'll see if we can get out his old thing. So this is another patient with similar. He came with cerebellar ataxia, and again his eye movements were abnormal, and again he had bilateral gross head impulse positive. This is his gaze evoke nystagmus. Okay. So he has typical cerebellar ataxia. And his head impulses, I don't know. I hope you all see it. Is it appreciated, or is this also frozen?
No, Sudhir, not appreciated. It's frozen.
Broken, yeah.
But we'll take your word for it.
Yeah.
Go ahead.
Both of them were head impulse positive. This guy didn't do the genetic testing, but he doesn't have absent reflexes. So It's not necessarily that everybody who has this syndrome will have absent areflexia, that is sensory neuropathy. So this patient, second one, has got a cerebellar ataxia with vestibular areflexia. And what I mean by vestibular areflexia is their VOR is almost zero. So what we mean by the VOR gain is, suppose I jerk his head 30 degrees to the right, then his eyes should jerk 30 degrees to the left in order to keep looking at the target. If it is 30 and 30, that is a gain of 1. If the gain is less than 8.8, then it is abnormal. So when I move the head 30 degrees to the left and his eyes move only 8 4s are, 8 3s are 24 degrees or less, that is abnormal. These people are almost zero. The eyes just don't move. So when you jerk it, the VOR is almost gone. And I have his video head impulse images also, but I didn't put those. So that shows almost flat responses. There's no response. The eyes just don't move. So the take home is, think of progressive myoclonic epilepsy in your IG, especially if it's refractory, if there's atypical myoclonus, if the E is low, or if there's some additional neurodeficit like ataxia in this patient, and do head impulse testing in the degenerative ataxias to look for canvas.
Very nice.
Sudhir, what did the MRI of the second patient show? Brain?
The second patient shows only this, what do you call, cerebellar atrophy. It didn't show that pattern like this guy, like that middle cerebral peduncle or dentate nucleus. It didn't show that thing.
So KB, that MRI of the first patient, is it sort of non-specific, you would say, or?
No, I think it's more for mitochondrial, no? That's more for mitochondrial.
Part of mitochondria.
Pol-G comes within the mitochondrial spectrum.
Yeah.
So 1 minute, I'm going to stop.
So by
That is the
mitochondria,
reason I was asking the question whether the brainstem was showing similar changes. That was the reason. Because
so
I was thinking
mainly
about mitochondrial.
middle cerebellar peduncle involvement.
Yeah, so
But
with the cerebellar peduncle alone, is drugs,
not the
CTX,
second
and so
patient.
on.
The second patient did not have that.
Yeah.
Okay, I'm just.
So I just had a question. So how does this Pol-G fit in with canvas then?
It's a different disorder.
Yeah.
The phenotype is canvas. That's what he said.
So that's what I'm saying. That it's not described. I think this canvas syndrome is, after all, a syndrome, and we are going to find more and more causes of that syndrome. So it's not really one disease.
Yeah, the gene is RFC1.
Okay.
Can I go to the next one?
Yeah.
Yeah. Should I start my screen share?
1 sec. I have to take this. Okay.
Okay.
Okay. So this second guy is a 70-year-old male. He came with slurring of speech and mild dysphagia for the last 2 months. And he had been taking therapy with a respiratory chap for BiPAP for sleep apnea for the last 1 year. And he used to get some cramps in his legs. So I examined him. There were no signs except mild lingual type of dysarthria. There was no weakness, no fasciculation, no other neurodeficit. His routine blood tests were normal. MRI brain was normal. We thought of myasthenia and checked the ACHR decrement. That was negative. The TRODAT was done and it was positive. So it was said he was thought to be some sort of maybe Parkinson. I thought initially.
But why did you do the TRODAT?
TRODAT, exactly.
He had some Parkinsonian features. He had a little mask-like face and he had a dysarthria, which we couldn't explain by any other thing. I thought whether it's a lingual dystonia. My first impression was an isolated lingual dystonia, but later he started getting mild mask-like face and things, so a little hypokinesia. And he was seen by a number of neurologists. So a number of them thought that he's some Parkinsonian syndrome maybe, and a TRODAT was done.
Sir, what was the history duration?
History was 2 months. 1 year, he had earlier, that's the past history, apnea, sleep apnea, and some cramps in his legs, like RLS, like thing, used to get cramps. And then now 2 months dysphagia and dysarthria.
So you think about Parkinson's plus syndrome, even if early dysarthria,
Yes.
sleep problems.
But was there clinical Parkinsonism?
Yes.
No.
There was mild. He was not gross Parkinson in any way. No tremor, no gross hypokinesia, but slight hypokinesia to begin with at that time. So that's why one of the DDs was maybe myasthenia, maybe a lingual dystonia. So he didn't have myasthenia. It was not fluctuating, and his symptoms would be persistent.
His sleep apnea was not related to his BMI and all. His BMI obesity was not there. Normal.
No, not grossly obese. No, he was routine Indian,
Normal.
a little bit on the higher side, not very obese. Okay, then he kept worsening. In September 2016, his hypokinesia became much more prominent. He developed anticholitis. He used to come in the clinic with his neck bent like that. His cramps in the legs worsened, and he would describe that he was getting some pulsations in the head which were spreading to the body. I didn't understand what were the pulsations. He had gone to Mumbai and had an EMG done, and during the EMG, it was noted that there was a tremor in his tongue. And later on, we could detect this tremor even clinically. So this is what he had a peculiar rhythmic tongue tremor.
My tongue is not able to give me a proper chair vibrate होता है. Okay.
See, I have actually, we had shown this case in the approach, so I've edited the videos and they're very short. But what he's having is a rhythmic, continuous sort of 1 to 2 hertz tremor of the tongue. See that again.
My tongue is not able to give me a proper chair vibrate होता है. Okay.
Not like palatal myoclonus, but just tongue moving like that. And later the tongue, that tremor spread to his face and even everywhere down. His whole face and the chest muscles would start jerking here. The same frequency. There was no, I thought of Whipple's disease, and but there was no eye movement, eye tremor. We still did his biopsy intestinal to look for Whipple's, but that came negative. Okay, so any ideas?
It's been very difficult to see the tremors. In fact, we didn't see much in the way of tremor. So the question is, whether the tongue stuff was not fasciculations, that was a tremor.
It was a tremor.
That was a proper tremor.
And it was a tremor affecting the tongue and the jaw muscles, the neck muscles, and even going right up to the chest muscles.
Sudhir, can you simulate the tongue movement? Because we could see the video.
Yeah, I'll show you. See, it's like basically like that. It was just
rhythmic.
It's a darting tongue.
Very rhythmic and continuous throughout sleep, throughout the day, all the time this was there.
How about celiac disease?
No, let's not jump to etiology just like that. I mean, why celiac disease of all things? I think the question is, from what we are being told, it's a syndrome that he consists of Parkinsonism and some tremor of his tongue and the adjoining muscles or the adjoining areas, right? Is that the syndrome? Or is there anything else you want to say?
Yes, that's a syndrome, I think.
That's a syndrome, right?
And there's a TRODAT which is positive.
Sorry,
and with the TRODAT which is positive. So,
somebody at the door, so my dog has got excited.
His mate is calling.
so Mohit, can you tell your dog to keep quiet?
I think it's
I'm waiting to get one.
So now, can you get tongue tremor or a jaw tremor in different forms of Parkinson's? That's the first question you ask. And there have been descriptions of people who have Parkinson's where you can get a tongue tremor, sometimes as a first feature.
Yeah.
There have been descriptions of people who have got jaw tremor. There have been people with a more extensive tremor in unusual types of what you might otherwise call Parkinsonism or Parkinson's. The other question you ask yourself is there a dystonic element? So in some people, especially when he started with the lingual element, you can get a dystonic tongue tremor and a dystonic jaw tremor. which is a part of the Parkinsonian syndrome. And the third thing you want to keep in mind here is whether the tremor which you're seeing, there are no other cerebellous features in him, in the limbs, for example, whether that tremor can be related to a cerebellar dysfunction. So you're trying to do first you try to do the systems as to what sort of things could be giving this type of tremor before you go on to say what may be the etiologies.
Sudhir, your audio is off.
Your audio is off, Sudhir. Sir, and Kailash, the frequency of the tremor at 1 to 2.
Now, it's been very difficult to judge because of what Sudhir was doing, whether it was 3 hertz, 4 hertz. The frequency of the tremor, the slow biorhythmic or slow ripples like very slow.
Actually, my audio is not switched off, is it?
Oh, we can
Now
hear
it's come
you.
back.
Now it is here.
Kailash, you put up your
See, the thing is, the tremor was.
I just wanted to make this point. Yes, at 1 to 2 hertz, if that's what you said.
Yes.
Tremors occur classically only in 2 conditions. One is palatal tremor, the other one is oculomasticatory myarrhythmia.
Yes, absolutely.
Characteristic. Others don't have that 1 to 2. If you're sure about it,
Agreed.
Yes.
If we see the combination, these low frequency tremors, as you told, with the palatal and
no palatal.
brainstem.
There was no palatal.
Not palatal, but it is spreading till the neck, you said.
Yes.
Not only the jaw, it is almost going till the
Correct. So
shoulders. So this kind.
But is that transmitted or is it truly involving those muscles?
Yeah, that
That's
exactly
the question, no?
It was truly involving. See the video, you can see this muscle is moving, the chest muscle was moving, everything was jerking. Everything was jerking. And in the same rhythm, and this guy felt it before we could see it. So he was describing that some thing. See that? And you see it on the neck also. And the whole face and everything was jerking.
And cognition is okay?
Cognition was fine.
So in the presence of brainstem, bilateral inferior olivary, that area pathology with because the respiratory centers are also located close by and so probably some etiology which is started with that breathing and then is involving bilateral dentate and that I do not know, but if we go by the combination within 2 months.
It is not palatal tremor.
No, I'm not saying that. I'm not saying that, but I'm just keeping the differential diagnosis because of the progression in such a way which has happened.
No sleep disorder.
Like very important is what is the tremor? What is it? Is it a dystonic tremor? I don't think it's extremely
low frequency like this.
So myarrhythmia is typically slow frequency, like 1 to 2 hertz, and it involves typically the jaw and the tongue area, maybe the palate, and it may involve the ocular this thing as well. So therefore, something causing or resembling myarrhythmia, and we should rule out a brainstem or a cerebellar lesion.
I thought it was myarrhythmia, and that is the reason I went for intestinal biopsy. Because
some of the audience have also commented.
Yeah.
Soham Desai is saying, was it really tremor, chorea, or fasciculation? As we also have a doubt.
No,
Dr.
no.
Joy Desai has.
We have done his.
But it appeared quite
5.
according to his description. So unlikely.
Fasciculations, the whole tongue is moving.
No, probably the audience might not have.
Somebody wants to know if this is a segmental myoclonus.
It was not myoclonus. It was a very slow sort of rhythmic thing. It was like myarrhythmia. I mean, I don't know.
Okay, so I think Whipple's would still be top of the list. You want to keep that one in mind. Yes. There's another condition where you can get a galloping tongue or a moving tongue with a Parkinson is syphilis. So that can give you a galloping tongue. So we want to make sure that the brainstem, etc., is okay, and that you've done a biopsy and make sure.
His MRI was normal. His intestinal jejunal biopsy was normal.
Ella, somebody wants to know if this could be MSA type C.
Yeah.
Yeah. So that's the etiology again. I mean, you want to know whether there are. That's why I said, has he got any limb cerebellar signs? Has he got any sleep disorder? anything
Yes.
else which would help us in that regard? We haven't been given that information.
Kailash,
Levodopa responsiveness also people are asking about
no,
levodopa responsiveness.
no levodopa responsiveness. He did have a sleep disorder. And what was the third thing Kailash said?
I said, is he got cerebellar signs in the limbs?
Cerebellar
Has he got a
signs.
sleep disorder? What
Yes.
sort of sleep disorder? Is it an RBD or is it RBD and non-RBD? Meaning on both sides, where you can get Iglun 5, for
Correct.
example.
He had OSA.
Did I learn 5? Yeah. Okay.
He had OSA, and the history was gradually at that last 1 year he had been on BiPAP for the OSA, and he had this now this progressive cerebellar, not cerebellar, progressive slurring of speech, little Parkinsonian symptoms, and this peculiar tremor. It was a tremor. It was not myoclonus. I mean, I know what is myoclonus. I know this was not myoclonus. This was not fasciculation. This was a very gross, slow tremor like that.
So
So
anyway,
he didn't have any parasomnias like, I mean, he didn't have an RBD and non-RBD.
He didn't have RBD, but yes,
REM and non-REM
he did
disorder.
develop RBD later. He did develop.
So other thing we were saying is Iglun 5 antibody related disorders. Okay, go on. Let's go on. Let's go on.
So I thought this was Whipple's minus the eyes. So this is from the net. This is a case of Whipple's, and exactly the same tongue and jaw movements, almost same thing he had. If you see this guy's tongue, but this guy has simultaneously jerking of the eyes, which my patient didn't have. But whatever he had in the tongue and jaw was same. So I thought it was myarrhythmia. It was a repetitive, rhythmic, slow movement, mainly affecting the cranial muscles. Okay, so December next year, I mean, this went on for a year. His speech was slurred. He could not balance now, even with the walker, started falling. He developed gross constipation and his cramps worsened. His anticolis used to come like that, walking. He had severe anticolis, and now he could not sleep lying down. He had to sleep in the sitting position. There was a lot of loud talking and gesturing in sleep. So he started getting RBD also.
So I missed it.
Can you speed it up a bit? Yeah.
Sorry?
Yeah. Go ahead.
We've discussed all this, so go ahead.
Okay, so what could it be? Now we've got Parkinsonian features. He's got a sleep disorder with RBD. He's got constipation, leg cramps. He's got bulbar symptoms like dysarthria, dysphagia, anticolis, a little gait ataxia, and myarrhythmia affecting only the branchial muscles, only here.
So I think the MSA becomes higher now up on the list, but Iglun 5 can look like this still, although this sort of tremor has not been described.
So Dr. Kailash, you have previously described that status dissociatus kind of phenomena, which initially started with the breathing problem, but now he is developing that vocalization, and probably if EEG or PSG overnight would show the complete, the background, total disruption of all the pattern N1, N2, N3, REM, because the evolution is now he has developed all these problems. So probably still that autoimmune thing is high on cards.
Okay.
Okay, so the thing was, is it some variety of PSP? Is it some atypical infection? Is it autoimmune? Is it MSAP and FTDLS? These were the things we thought of. And I thought this was probably anti-glon. It was insidious onset, slowly progressive. There was a sleep disorder prominent, which later started getting RBD-like thing. He had movement disorders, including Parkinsonism. He had myarrhythmia. So Kailash, myarrhythmia has been described in Iglon. I'll give you the reference.
You were saying tremor, so rest of it all looks very much like Iglun 5.
Yeah, but this myarrhythmia has been described. I'll show a case. We have presented it in Neurology Journal, myarrhythmia. Okay, so cranial, he did have cranial and cervical dystonia, a little, there was no myoclonus, but they can have choreoathetosis and various things. So they can get supranuclear gaze pulses, nystagmus, failure, everything, lots of things.
PSP.
So the thing here is that although all the people are looking at their atypical PSP cases, actually, if you look at the literature, Iglun 5 is more likely to be an MSA lookalike because they have a lot of autonomic features. They have the RBD. Remember, in tauopathies, you don't get RBD. So this is a very big differential. When you get such sort of sleep disorder, tauopathies are out. You don't get that in CBS. You don't get it in PSP.
He did have
So when you see somebody with autonomic, with enterocolis, with the REM, non-REM sleep disorder, it's more like an MSA, and many of them also have ataxia and so on. So my handle now is that this is more confounding for you when you're facing somebody with an unusual MSA rather than an unusual PSP.
Yes, because he didn't have actually, you're very right. His eye movements were completely normal. He had anticolis, he had severe constipation. He didn't have orthostatic hypotension or urinary retention, etc., or anhidrosis. He had this motor hyperexcitability. So these cramps are described, very painful, severe cramps they can develop. He didn't have fasciculations in the legs or stiff person or hyperexplexia. There was a little anxiety-like thing, but that of course could be secondary to his symptoms.
Again, his age is odd for MSA, right? He's 70. So that would again.
Yeah.
But the oldest age of MSA pathology is about 72, 73. So it's still within that range. But it's all these other features.
Okay, so anyway, I thought, could it be Iglon? But we sent his anti-Iglon. I sent it to Dalmau, but the Spanish authorities sent the sample back. They didn't allow it to go through the customs. So I sent it to India, to Kochi, or wherever that, I forget the guy.
You are in India.
Yeah, first, I didn't know it was not being done in India at that time. So first I sent it to Dalmau, and then later on what's the person who, I forget his name, who is doing.
So we are running short of time.
Amrita Cochin. That's an Amrita Cochin.
Yeah, so I sent it there, but it was negative. So I thought, could it be this? And so we gave him empirically methylprednisolone, and he improved partially. So I just discussed with the family, and I said, it's possibly this could be, and we started him on rituximab. And over the last 2 years, he is much, much, much better. His speech is better. His swallowing has become normal. He now walks without support. He sleeps without a BiPAP. He's sleeping supine. Tremor is now gone. There's only very little left in the tongue. He does not feel that pulsations, no cramps, no constipation. So everything has improved. His rituximab dose was due last month, but because of the COVID, I have told him not to come just now. And he's much better now. He's walking without.
Okay, come back.
We'll stop over here. He's much better. This video is about a year back, and now he's even better. This is the myarrhythmia in Iglon. This was described in Neurology in 2018, October. This is one of the teaching images. So this is exactly what the patient had. My patient had in the tongue also. This is only in the jaw and branchial muscles. Okay.
But you're not able to see that.
The video doesn't work.
It doesn't work, and I think we'll need to.
But you can see that this is teaching images, Neurology 2018.
Yeah, sure. That's great. That's a very good teaching point.
We'll go on to the next case, sir. We are running short of time.
Just one sec. I saw another case. I'll just take half a minute. One here, history of progressive slowing, anticolis and sleep disorder. But this guy got lost to somewhere. Again, he's got the same tongue movement. I don't know if you all are seeing.
No tongue.
No, not seen.
Nothing is moving.
Okay, forget it. I'll send the case to you, Kailash, later on. You can
Yeah. Thank you so much. Yeah, great.
Thank you, sir. Very nice cases.
It's
I'll
Petrus
request
now.
Dr. Petrus.
Yeah.
Dr. Petrus to start.
Start sharing, Petrus.
Yeah.
We can share screen now. Yes.
Good evening, everybody.
You can go full screen. Yeah, great.
Yeah. So this is a 47-year-old gentleman who's from Jodhpur. He came with a history of difficulty in speaking since the last 12 months. He had pain in the hands and fingers since the last 6 to 7 months. And he had a fair amount of imbalance when walking, and there was a fair amount of rapid deterioration. His wife reported behavioral changes. There was a lot of forgetfulness to the extent that his job was being threatened, and that he had lots of excessive sleepiness. and would fall asleep even during a conversation. And he had a lot of sleep disturbance at night. So on the exam, there was postural hypotension. He had some amount of bradykinesia, rigidity as well. And there was a lot of cognitive impairment, as you can see. Now, I hope that the video plays. Is it visible at your end?
Yeah.
We can, it's a little choppy, but we can still see.
Yeah, so he's bradykinetic. He walks with small steps, and he's also very confused. There's a lot of imbalance. He's confused even with the instructors, examine what he's told to do. So yeah. So this is what we have.
Can you show the first slide?
So I think again, the question here is that he has a Parkinsonian condition. He's got, along with that, some sleep problems. You mentioned that he has cognitive problems. He's got autonomic problems. So if you were thinking about it, conditions like diffuse Lewy body disease, which can give you autonomic dysfunction, etc., excessive daytime sleepiness, etc., would come into the context. But he's rather rapid. So because he's rapid, again, things like IGLUN5 come into the context once more in this sort of a case as well. So his imaging would be helpful, and I would certainly keep, again, IGLUN5 in mind. There are, of course, FTDPs, paraneoplastic conditions, etc. But I think this sort of configuration with the autonomic, with the sleep, with the dementia, IGLUN5 is high on the list. It's not MSA because of the cognitive involvement. So if at all, either DLB or things like IGLUN5 and some unusual FTDPs.
Some of the audience have
hallucinations and things. You're still thinking of DLB first.
With the autonomic involvement, with the cognitive involvement, with the Parkinsonism, DLB comes in. Hallucinations may or may not be present. They can come with the drugs or come later.
Okay.
If they are there, good. If they are not, but you know.
Ravi, you want to read the audience?
Doctor, the audience are commenting. Dr. Joy has written chronic hepatocerebral degeneration, whether it is possible. Anjali Choksi, Morvan syndrome, and Soham Desai, Lewy body spectrum. So autoimmune and
So yeah, so autoimmune and DLB type of picture. Now, whether he's got some iron, that we need the MRI. That's why I said we need to see the imaging.
Yeah, we'll show that. There was no
MRI is abnormal. So the Trodax scan is slightly abnormal, right?
Yeah, it's actually not too bad. There was reasonably good uptake. It was reported as normal.
It is asymmetric.
Yeah, but that can.
Yeah, I think it's just the images.
The Trodax is not a very good scan.
Yeah, so this is the we extensively worked him up because he was a young guy with a rapidly onset Parkinsonism, with cognitive impairment, and this is the labs. HIV negative, B12 was low but corrected. We even looked for autoimmune encephalitis, as was pointed out. EEG didn't show really anything specifically. The initial MRI was absolutely normal, but a repeat MRI, in fact, showed significant brain atrophy with ventricular megaly. And that's the repeat MRI. Now, with this, what do you...
So with the excessive sleepiness and so on, you're thinking of a slow encephalitic process, which with the ventricular atrophy going on, with the atrophy of the brain going on, make sure that the CSF, etc., has been done, no inflammatory markers, things like that you got to keep in mind.
Prion disease also, people are commenting.
Yeah, prion disease
And syphilis.
HIV and syphilis.
So infective, inflammatory disorders have to be kept.
Is progressing rapidly.
Okay.
Okay, so yes, that was what we thought, the CSF. So here it is. We already discussed.
Slide is not moving.
Your slide is stuck.
So serum VDRL was negative.
Negative, yes.
TPHA is more sensitive.
So this has blown off, I think, and just joined back. Yeah. Are you with me?
We missed the last slide, I think.
Yeah, yeah, sorry, I think the connection broke off.
We had syphilis.
Oh.
Yeah. So CSF TPHA was positive, and we treated him with benzathine penicillin, much improved.
What
He
was
later on,
cell count?
I'll just have to go back. So this is the improvement just at 6 weeks.
What did the CSF show?
I'll just go back to the earlier slide. So CSF 81 protein, 28 cells, 90% lymphocytes, and positive TPH.
81 protein, 28 cells.
Yes, so that's what I mean. With such a subacute history, you would want a CSF.
Yeah.
Yeah. And the other thing is that once the Trodat scan is normal, things like DLB, all of those things go out of the context. So you cannot get Parkinsonism related to DLB or anything like that with a normal DAT scan. A DAT scan has to be abnormal then, or a Trodat scan.
One of the audience, Dr. Vijay, has told about this CSF VDRL.
So how
Okay,
do
so we'll go to the.
I had a question. So how do we explain that his Parkinsonism with absent Trodat abnormality? Because I think he said that he had Parkinsonism.
So you can get Parkinsonism which is postsynaptic. For example, Huntington disease, the DAT scan is normal. Dopa-responsive dystonia, the DAT scan is normal. Drug-induced Parkinsonism, the DAT scan is normal. So there are conditions which give you Parkinsonism. So the DAT scan only shows you the presynaptic disorders.
Correct.
So if you have a postsynaptic problem, you will not see an abnormal DAT scan.
So we go on to the next case. Very nice.
Yeah, so this is the last follow-up. Just showing that improved, and I've got just one more slide. And from hopeless, it's been a very good response.
Was he left with any sequelae of cognition?
No, none.
Cognitive?
None.
So the scores all normalized completely. But usually they are left with some sequelae.
They improved a lot. So just to highlight what Pankaj was there are a lot of papers which are showing Parkinsonism as part of the neurosyphilis spectrum. This is a case with 169 cases of neurosyphilis, 7 had movement disorders, and another paper also in movement disorders showing Parkinsonism as part of neurosyphilis. So I think the learning points are that we need to pay attention to the atypical features in clinical presentation. In this case, it was dementia, rapid decline, autonomic dysfunction. As Dr. Kailash pointed out, a normal CAT scan is a red flag that makes you point that this is not dementia with the others. And neurosyphilis is a rare but treatable cause and should be kept in mind when there are typical features.
Dr. Petrus, some audience are asking the likely source and whether wife was tested and other family. So
wife was negative. Wife was negative. Wife was negative. He had a contact history.
Contact history
Yes.
was there. Okay. 3-4 people have commented in that.
Good.
Nice.
Without having contact history, it would be difficult to suspect.
Thank you, Dr. Petrus.
Okay.
We'll go to the next
Thank
case.
you. I'll stop screen share.
Who's next?
I come to you.
Next is Pankaj.
Very nice cases.
Yeah, hi. Can I start?
Yes, yes.
Yes.
Yeah, so just a disclaimer that this is not one of our usual find the diagnosis kind of cases, but just an interesting journey of a patient we recently treated. So this is a 68-year-old lady, housewife from Pune, and she lives with her son and husband. So she says that her hands are shaking for the last 8 years, mainly when she's holding an object. And it's in both hands, left more than right. And she also has some intermittent head shaking, especially when she's anxious. So there is progressive worsening in the last 4 years, especially in the last 2 years. So can you see the video okay?
Yeah.
Yeah, it's better than the others.
Pankaj, have you clicked that button for optimize video? I forgot to do that.
Ah, yes. He must have done that.
If you click that, the videos run even better. I forgot to do that.
Where is that button?
Just stop the sharing. Just stop the sharing for a minute. 10 seconds.
Sir, should I first go on and finish? Or?
Yeah.
No, I just wanted to discuss some features, but should I play it again now?
If the video is not important, then it's okay.
It's important.
Then the video is playing very well, actually.
Yeah, very nice.
Fine. It's okay.
So can I finish and then I can?
Yeah, finish, Pankaj.
So no, as you can see, her disability is more when she is holding an object, and most when she is, for example, eating and drinking, and this is causing a lot of trouble.
Slightly asymmetrical, no? Left is more than right.
Left is definitely more than right, and in fact, this was her. This is what she told us as well. So are you able to see that while eating also, she has great difficulty while pointing the spoon to the target, and she's in fact spilling her food, and her husband is taking a step back because he knows that the food will be spilled. So she is very disabled. So she cannot hold a cup, and she cannot bring a glass of water to her mouth, and she is unable to bring food to her mouth. So one of her main things is that she can't cook for her son who lives with her, and she has to, her husband actually is feeding her for the last 4 years. So you can appreciate the postural and kinetic tremor, but mainly it is a kinetic tremor in both hands. And as she reaches the target, she has tremendous shaking. You can see that her head is not shaking much. It's mainly the hands. And when she actually holds her hands out, the postural tremor is much less than the kinetic tremor. And again, she has a lot of trouble when she brings it close to her mouth. So can you see this also?
Yes.
So her hands are, as you can see, mainly affected. Head is very mildly affected. Her voice is not affected significantly. She has 2 other family members, her mother and her mother's sister, who has a milder shaking of their hands. MRI of her brain is normal. So any comments at this stage?
And is she related to you?
That is a very good question, sir. but she is not. She is
Not related to
Maharashtrian,
you?
and I am a Marwadi, so I am not related to her at all.
Okay.
Vijay Kataria has also asked the same question about Agarwal background.
Yeah, she is non-Agarwal. So anyone else wants to?
On the face of it, she will fit into essential tremor, yes.
Right. So she does have essential tremor, and I think it is quite typical. So she was given propranolol and benefited around 10 to 20%. She did not have any side effects, but slowly, because her amount of tremor is quite severe, therefore we went up to 120 milligrams a day. Then after that, we added primidone, and she benefited another 30 to 40%. And so we kept slowly increasing the dose to quite a high dose to 300 and 400 mg. She developed some sedation despite this very slow increase, and therefore we had to reduce the dose again. But as we reduced the doses, the severe disabling tremor appeared again. So really, I mean, it was quite difficult to control. And we added some other drugs, but she did not benefit at all. So we know that the treatment of severe essential tremor is deep brain stimulation, or there are some other techniques, but mostly DBS or thalamotomy of the VIM nucleus is used. And this certainly was a case that deserved consideration of DBS or thalamotomy, given its severity and its disabling nature. So we know that the cerebello-thalamocortical circuit is the one that is responsible for this severe tremor, and it is indeed the target of treatment for essential tremor and many other tremors. And the VIM nucleus is the target, and this is well known. So it is interesting that if you look at so for those of us who are involved in deep brain stimulation, so if you look at where the VIM is, it is actually just 4 mm above the STN, which is the classic target for Parkinson's, and we commonly do DBS of the STN. But the VIM is 4 mm above in the ACPC plane. The laterality is very similar to the STN. So in fact, it is just above the STN. This is a diagram of the various nuclei of the VIM, and we know that we are looking to target this small pink strip over here, which is the VIM nucleus, and the VOA and VOP are targets for dystonia. And the green area is the sensory input into the thalamus, which we have to avoid. So we are looking at targeting this small area of the VIM. So here again, you can see that the red area is the hemisensory area, which we have to avoid. And we have to get into this green area in the lateral part of the thalamus and just medial to the internal capsule. So this is also very interesting, and we usually show all this in DBS workshops, but I think it will be interesting for a general audience of movement disorder enthusiasts as well. If you look closely, there is a homunculus in the VIM nucleus as well. As we know, there is a homunculus in almost every nucleus in the basal ganglia. So this is the VIM nucleus in yellow, and you can appreciate the hand area, which is of course the most affected body area by essential tremor, is somewhere in the middle. The leg area is little laterally, and the head is a bit medially. The green on the side here is the internal capsule. Of course, this has to be avoided. And the green below is the sensory lemniscal area input, which is again to be avoided. So one has to target this yellow area, and that too the hand area. So a little bit towards the center and laterally. So if one is too lateral, one will stimulate the internal capsule. Too posterior, sensory stimulation will occur, which is undesired. Too medial will not produce good effect, and too anterior will again not produce, because you're not in the hand area. So these are things that we have to take care during DBS. So here in this diagram, you can see the VOA, VOP, VIM, and VC, but in reality, the VIM is actually very small compared to the VOA and VOP. So you can see that just before surgery, you can see that she's being asked to draw the Archimedes spiral, and she has a lot of tremor and great difficulty with doing the spirals. So this is just before the surgery, and indeed the frame is also attached. You can see she's all over the place. And the left is much more than the right. So can you see this video?
Yes.
Yeah.
So then we started with the left brain. We used a slightly different lead, a lead which is slightly longer compared to the regular lead that we use for ST and DBS. We started with the left brain, and we use typically 3 or 5 trajectories. Those of us who are involved in DBS may know that we use central, anterior, posterior, medial, and lateral. All can be used, but here we used only central, anterior, and posterior. So as the electrodes were lowered into the left whim, you can see that there is an immediate improvement in the spiral drawing. So this was immediately when the electrodes are lowered. So stimulation not being started, but there is already an intraoperative reduction in the hand tremor. This was of course very exciting. This immediately tells us that you are in the target, and so this is a moment of happiness for everyone who is in the ward. So then we asked her to use a spoon, and this was the functional task which was actually most difficult for her. And you can see that on the right side, where the electrode has already been inserted in the left contralateral brain, spooning is now much more stable, and she will in a minute do it on the other side, which is not yet touched. The right brain is not touched, so you can see that there is a clear difference, which shows you that the right hand is sort of treated. So we were fortunate here to get good responses with the central trajectory that we chose. And as we increase the current, we find pyramidal side effects as expected at high current. So this was also confirmatory of the target. And the same result was obtained on the other side. So post-operatively, intraoperatively, the tremor had disappeared actually, and then she was quite confused on day 1, as happens after DBS, and then on day 2 and 3, as she emerged, the tremor was almost completely absent. So here she is drinking water, and she says on camera that she's drinking this way for the first time in 4 years. So this was very gratifying for the family and for our team as well. And you can see the great difference in the way she's using her hands. So this sort of lesion effect persisted for a couple of days, but then on day 4, there was a mild reappearance of the tremor, and we know this happens, especially on the left side. And this is when we started the stimulator, and the bottom contacts in the WIM were most effective. And again, the tremor was completely blocked at low voltages at the bottom contact. So you can just see pre and post DBS and the spirals, and you can see that there is a marked improvement. So this was quite gratifying. Now, just below the WIM, there is another target, and this is becoming a very emerging and new target for essential tremor. So we know now that there is a DRTT, or a tremor tract, and along this tract of white matter are targets which effectively block tremor. So this is called the tremor tract, and DTI is increasingly used to visualize this tract, because the targets such as the ones in yellow over here, the WIM, the posterior STN, and the CZI, these are all targets that are lying in this brown line, which is the line of the DRTT, and the tremor sweet spot is in this brown area at any of these 2 or 3 areas. So the CZI is actually above and behind the subthalamic nucleus, and it can now be targeted in the same trajectory as the subthalamic nucleus. And this is of great practical value, because it becomes easier when you can target two structures in the same trajectory. And STN is very commonly done for Parkinson's, and therefore you can target VIM and the CZI in the same tract. So
That is, you had taken a longer electrode?
Yes, absolutely. So we take a longer electrode because we can leave one bottom contact down with the hope that you can stimulate some CZI area, and therefore even if the VIM is less effective, at least that CZI electrode, which is and we suspect strongly that in our patient, the bottom electrode was extremely effective and at very low current. It had great effect. So certainly there was CZI stimulation by that bottom electrode.
Why did you use the long lead? Your STN is even below the same lead would have done?
Yeah, so we use that 338 7 or 9, can't remember which one. The one with the more gaps between the 4 contacts. So
Okay.
the longer lead.
Longer lead, like you use in dystonia.
Right.
Yeah. Okay.
So just a very quick sort of mini review on some articles about the PSA and the CZI. So the PSA is the posterior subthalamic area and actually contains the CZI, not the VIM. And this area is now being targeted by various techniques. In fact, now CZI has emerged as such a strong target that a comparison of this is commonly done, and CZI is emerging in several reports to become to be a more efficacious target versus the VIM. And it also may be more efficient in terms of current utilization. So therefore, it is becoming more and more popular versus the VIM, which has been the traditional target. A long-term benefit. So this paper found that the long-term benefit over 3 or 4 years was actually slightly better with VIM, but CZI came quite close. So again, CZI did okay over there. And as I said earlier, using the same lead to cover both these targets is a simple and easy way to treat ET, and you can target both in the same lead. So just 2 months, and this lady was operated 2 months ago, and now she's at home, of course. This was 1 month after, and a stimulator is on. So she is able to do a lot of her activities, and it is extremely gratifying for us when she tells us that she's able to eat and drink very well, and she's in fact able to cook for her son, and she has let go of her cook, her maid, and we did not think that we could achieve this when we first saw her. So just the take-home message is VIM DBS can be very useful, and new targets like the CZI are emerging. There are new ways, especially with DTI imaging, to visualize tremor tracts, for example, the DRTT, and now using that to target DBS more effectively is becoming more and more popular. And VIM is a very useful target in various movement disorders, and if our surgeon colleagues can target the VIM along with us, then we can treat a variety of refractory tremor syndromes, Holmes tremor from various causes, orthostatic tremor, ET, of course. So, and one more thing is that somehow VIM cases are much less than STN cases in most movement disorder centers. If you ask, and even in your own experiences, I feel by a factor of 8 to 10, sometimes the commonness of VIM is quite uncommon, but it can be very effective, as we see in this case. So we just wanted to share this case and the journey of this particular patient. Next.
Good case, sir. Good
Nice
case.
case.
There's a question: does head tremor and vocal tremor in ET improve with VIM DBS?
Yeah, so certainly head tremor will improve, and as we saw even in her, not captured on the video, but she had at least a mild degree of head tremor, which is completely gone. Vocal tremor will also improve, although as time goes on, you know that often there may be re-emergence or tolerance to the effects of DBS, especially in essential tremor cases. So often over time, the DBS may lose efficacy, and these symptoms may return. So that is one of the long-term problems with ET DBS.
That makes you wonder whether there is a lot of dystonia in this.
Yeah, exactly.
And
Well,
at some stage, you would want to think of a GPI as a target in some cases.
Yeah, well, I'm not sure because I mean, again, this is entering into that debate of whether dystonia is. But I mean, it is certainly we know that some patients are very clean and clean cut essential tremor like with minimal or no dystonia. I think you will agree with that, and especially in those cases where it is clean cut, like in her, the VIM can be very very useful.
Dr. Sanjay Pandey has commented about the phenomenology. So has written, is it ET or ET plus or dystonic tremor? Going by the first videos that you had shown.
Yeah.
So what is your comment on that?
You know, when the hand comes very close, you know, you can feel that there's an odd posturing. If you see her drinking, when she's very close to her mouth, there is like an odd posturing suggestive of it.
Yeah.
So actually, we did not think that she had significant dystonia. So if we were, you know, I guess.
I think tremor is very dominant here.
Yeah.
But in any case, she has responded well. No?
Into an ET more than anything else, like just like Pankaj said, because of the way it is presented. What do you think, Mohit? Do you think there is a dystonic component? Definitely.
Yeah, there is, but I agree with Pankaj. The tremor part is so dominant that you can't not think of doing a thalamic stim in this patient.
Somebody wants to know, Vijay Kataria wants to know if there is a role for levodopa in these tremors.
So we did not try, and I would also not try if I saw her again, because I mean, here it is quite clear that it is a kinetic tremor. She has almost no rest tremor, you know, she's a kinetic tremor more than postural. So the phenotype being ET, and there are no other signs of, so I mean, and dystonia also was not enough for us. So I would not use levodopa.
KB Kailash, you're there or you've gone away?
I'm here.
I thought you'd gone to fetch a drink or something. Kailash,
I have my drink.
Okay. What I wanted to ask you is that, you know, some of these patients, when you do a DBS with VIM stimulation, initially they do quite well. And then they come back with a recurrence. Have you done a GPI stimulation as a subsequent session saying that, well, the dystonic component has somehow overtaken the tremulousness?
No, we haven't, because, you know, I think what is required now is where you take people with the pure ET syndrome as per the new classification versus the ET plus or the clear dystonic syndrome, and do the VIM on these people and do GPI on the ones where you think there is dystonia, and see if there is a better outcome over the long run. At the moment, all the surgeons and everybody is still stuck to the VIM targeting as the final pathway. I mean, there is some rationale to that. That is the final pathway, and the zona incerta is thought to be a favored target. So it's very difficult to get people to do the GPI if there isn't a overt dystonia. The surgeons don't agree.
I just wanted to know, do you all regularly use up to 400 milligrams of primidone? Because I find patients are just not able to.
Primidone you only give to your enemies. If you don't like anybody, you give them primidone.
No, sir, we are using it.
So Dr. Bhatia.
Even I'm using it a lot.
I never use primidone.
That's because you don't like some people, then you can give them primidone.
No, we get good responses.
Other option for the people who
I just had a
bad signal.
I think you are zonking out.
And I mean, if you want, and you want your enemies to forget you, then you give them topiramate.
They forget bad words. They forget words.
But Dr. Bhatia, I mean, there are patients in whom it has produced a very remarkable effect. There are many patients. I don't know whether it is different in the West, or at least Indian patients with essential tremor.
How long have you followed them?
No,
How many of them become ataxic?
What about cognitive?
What happens to them in the long run? Have you got 10-year follow-ups on your primidone cases?
No.
Primidone is a bad drug.
They must be becoming very drowsy.
I'm telling you.
Cognitive function will go down.
I never use primidone.
I also don't.
We use it regularly.
Somebody's come out with a 25 milligram, even that I find it difficult. I have not used.
Shall we move to the next case?
Yes, sir, we'll go to the next.
There is one question. I'll probably take this question. Did you discontinue medication?
Yeah, so the patient, so actually there was nothing left almost So therefore, I mean, she's not on any medication now. But I mean, if it comes back, we will of course add some.
You'll have to stop sharing screen so I can now go on.
Okay, thank you.
UMS to take over.
Yeah, I'll share.
UMS, if you have videos, click that button at the bottom where it says optimize for video.
That's optimized for your own video, no? Rather than the video of the...
Share screen, when you click share screen, there is an option downstairs at the bottom which says optimize for full screen video.
Okay, now I hope this runs. Can you see it well?
Yep.
I will probably go through. Okay, now. Okay, this is a 13-year-old girl with normal birth and development, complaints of falls of 2 years duration occasionally, trips while walking, and has upgoing of toes. She has complained of difficulty in getting up from squatting position for the past 1 year. Whole complaint is only 2 years' time. She is aware of slippage of footwear for the past 1 year, difficulty in gripping. At this stage, I want to thank Dr. Ishwar Das. I hope he is online for referring this patient to me. So this is a video. I hope this runs well. Can you see it well?
It's okay.
She must have. Okay, I'll leave it to your imagination.
The left leg she lifts up and dystonia or left leg.
The video is running okay?
Yeah, video is running okay.
Yeah, a Mac. All of you. I'm promoting a Mac. Little toxic in the limbs.
ತಪ್ಪಿಲ್ಲ ಪರವಾಗಿಲ್ಲ ನೋಡಿ ಸ್ಟ್ರೈಟ್ ಇದೆ
She has these movements in her tongue, nothing in the palate.
This seems to be lingual day.
Lingual. Phenomenal. So,
palate.
ಲೆಫ್ಟ್ல பாருங்க ரைட்ல லெஃப்ட்ல ரைட் மேல கீழ மேல
the movements are basically normal, so it's good.
மூக்க பாரு
Any abnormality in the eye movements?
Mild impairment of convergence.
Convergence
is okay.
leftல பாரு
So complete.
ரைட்ல லெஃப்ட்ல
Seconds are pretty good.
மேல கீழ
The vision and fundus were normal. The reflex were brisk. Plantar was extensor bilaterally. And she had a normal cognition. The routine blood investigations normal. Acanthocytes absent. She had done all this before she came to me. CPK was negative. Ceruloplasmin normal. Any thoughts at this stage?
Magnesium transporting, a little that toe walking plus this.
Well, let's do the syndrome again. Always do the syndrome first. So what's the syndrome?
Syndrome is ataxia, of course, and a little bit probably.
Is she ataxia? She has minimal ataxia of the upper limbs.
Yeah, spastic and a little prominent. Unlike just routine spastic, she's tending to have difficulty distally with tripping while walking. So spastic foot drop like thing.
Isn't there a
And what about the tongue?
Yeah,
Do you think that there's an abnormal posture of the foot?
Yeah,
It appears like a
It's really
dystonic.
dystonic, no? So she's got an abnormal posture of the foot. She's a bit clumsy. There's a lingual involvement with some dystonia. Is very young. So I want to know about alpha fetoprotein and things like that. Before
eye
you're
movements.
talking about investigation. So you're talking about dystonic ataxic syndrome in a young person.
Yeah, correct, sir.
That's the
Alpha
sort of thing.
fetoprotein, you're thinking of ataxia telangiectasia?
Yeah, AT and its variants can give you dystonia and ataxia as their main feature without even sometimes ataxia.
But no ocular apraxia at all?
No, not needed. Not needed.
Okay.
And of course, you're also thinking about things like, don't miss treatable disorders and etc. But with the ataxia, if it is prominent, with the dystonia, young onset dystonia, ataxia, things like AT and the ataxia, recessive ataxia differential comes into context. And imaging would be helpful, of course.
What is seen in the tongue, Meenakshi, exactly?
Tongue, she has a dyskinesia. I feel she has a tongue dystonia.
Okay.
That's her imaging.
Wow.
So
There's an NBI.
and it can brain ion accumulation. Is a CT done? Make sure that's not calcification.
It's not a calcification. CT has been
Okay.
done. Training was done.
Here we can see that the pallidum, the caudate and putamen seem relatively okay, or are they? No. And
We saw that.
I didn't see it.
In that peak point.
Yeah,
So I want you to particularly see this MRI and see that if there is something specific, that's the idea of presenting. I want you to firstly look at this and this. See that
So the nigra is involved, the substantial nigra is also involved to a large extent.
Yes.
As the
Look at the GP. Is there anything specific that you see here? You see here too in the coronal? That's true. That's what I want to highlight on.
There's a sort of a white area between the two GPI.
In one of them, you get a white sort of hyperintense streak
between the
medullary laminary streak.
Like Kailash said this.
There's also a lot of involvement of the midbrain and the in that area. So things like MPAN, BPAN, etc. come into context.
Right.
There is a T1 halo on T1 if you have T1.
Well, I don't have it here. But
T1 halo in the substantial.
I thought this was very representative. Somebody said, and yes, she did undergo the genetic testing, and it is MPAN, and that's what she has. Why we showed this case is about, this was pretty old. This is not a new one. C19 of 12. The characteristic things are the spasticity, the Babinski sign, and the dystonia. Though if you see this combination, I think we should think about MPAN. MPAN, we think that sometimes it's about peripheral neuropathy alone. But see that spasticity, as I showed, because in a very high percentage, Babinski is positive, and you have dystonia too. And if you look at the MRI changes in NBIA, see that in MPAN, there is a hyperintense streaking of the medial medullary lamina of the GP. And that's what we can go back and show you. I think that's pretty, the MRI, you can see that there is an hyperintense streaking that happens. I think that's pretty classical. You can see that the coronal pretty well. I think that's pretty classical of an MPAN. The idea of showing this case is primarily that. So I think MPAN should come into the differential diagnosis. Whenever you see an NBIA and the patient has spasticity, then it's not just about, because for a long time we do think about axonopathy, neuropathy, but spasticity is also a component. That's all. I just wanted to show that MRI and say about the case.
So many of the attendees
spasticity
are right.
is seen in many of these disorders because these are the conditions which are called the pallidopyramidal syndromes.
Right.
So spasticity is in fact very common in these conditions. It's there in NBI1, NBI2, In almost all of them, you can get spasticity. In fact, for example, Plateau G6, in the end, they become like ALS, or rather than ALS, PLS. They are left with severe spasticity. The hypokinesia, etc., starts going away. So spasticity is very common, and that's why they were called pallido-pyramidal degenerations.
Yeah, and I really wanted to do that. This MRI many a time can give you an indication of what you're dealing with.
Yeah.
And that is something that this was pretty classical in this case.
Nice case.
Very nice.
Case. So some of the audience have given the right answer. Heli Shah, Dhruv Batra, and I think many other people have also. So
Yes.
very attentive audience we have.
Wonderful.
We have a very bright audience.
I am stopping sharing.
Kailash Bhatia is next.
Do we have
Yes, sir.
time? Because we
Yes,
are running
sir.
out of time, no?
No, sir, we are on time.
We have time?
Yeah, I have finished on time. We have
Okay.
Kailash,
Yeah.
go ahead.
sharing. Yeah.
Yeah, 1 second, sir. 1 second. Let me find. Can you see my slides?
Yes.
Yep.
You see the fourth slide.
Okay. Okay, so usual rules, please don't download these videos. So this is a 52-year-old woman who complains of loss of balance, coordination. She describes postural giddiness, and she's become slow for the past 2 years. The first part, she's describing her symptoms. So I'm going to just move forward in the interest of time, or unless you want to hear her.
We have time, Kailash. We have.
Okay. So the Italian doctor is asking her, what is bothering you more? Off balance. I fall. If she trips, she can't hold herself, she falls.
How many years, sir? It's hidden behind the box.
2 years.
Okay.
Can you hear her?
No.
No?
Just barely.
So she's saying she feels dizzy.
Can you increase the volume on
when
your?
She gets up.
Increase the volume on your computer.
Yeah.
1 second. Oh, what the hell is going on here?
Kailash, the best thing would be to you just tell us what is she saying.
Yeah. I think
Okay.
that's what she said.
All right. So as I said, she said that she feels giddy when she, so I'm just moving forward.
Yeah.
So she gets flashing lights in one, occasionally in one hemiframe, like zigzag lines. So we just move forward.
He was playing very.
So there's decreased shoulder shrug on the right. Eye movements are okay for slightly reduced up gaze.
Yes.
She's looking for a rest tremor. Sometimes we ask them to count from 100 from backwards. That's the important part. And there's a difference between the right and left. She's slower on the right compared to the left. Same size as the shoulder shrug being decreased. Reflexes are brisk. They're generally brisk. Plantar, she's flexor there, despite the stockings on both sides. Nothing there, but 1 or 2 beats of clonus here. She's not bad.
Slow on the right compared to left.
Yeah. She's a bit clumsy, but they're there on repetitive tasks. A little waver, nothing, little bit.
This must make it more difficult.
And she walks with a wide base gait with decreased arm swing on the right. And a little bit of a freeze at the end over there. And again, a little, when she's turning, she's a bit cautious. So, 52-year-old woman, you saw the signs. She complains of loss of balance and coordination. She's become slower in the past 2 years. And you saw the signs, her postural reflexes are affected. She walks with a slightly broad-based gait. She's a bit clumsy on doing cerebellar tasks, but not grossly abnormal, but clearly the wide base gait. And she couldn't walk tandem. We haven't shown you that, but she couldn't walk tandem. And the reflexes are brisk.
And how's the speech? How's the speech?
Her speech is, you heard her, it's okay. It's not slurred. And she has no nystagmus. She got slightly reduced up gaze, but that's it.
Did you have a postural drop in BP?
Okay, so we'll come back to that, but what are your thoughts?
So she appears to have a
MS would be the
Parkinsonism and of 2 years duration and mild restriction of vertical up gaze. And also she has some visual complaints. I think she was talking about those zigzag lines. So
So those, just to get that out of the way, she has also got migraine. And what she was describing was a migraine aura. So we can discount that.
Okay.
Okay, so MRI.
Autonomic test normal.
Yeah. And this giddiness which she was describing was actually a vestibular. So when you asked her, what exactly is happening, she would say that when I move my head from one direction, that's when I feel giddy. So it wasn't that when she stands up, and she had a previous problem, a BPV type of problem.
What about head impulse or
The vestibular reflexes, the head impulse?
head impulse?
We don't have Sudhir Kothari with us, unfortunately, so we were not able to do that. Let me just go on. So what else do you want? You're at Queen Square. You can do imaging quite easily, no problem. All sorts of imaging.
That scan.
So that's first, yeah.
That's normal. Okay.
Family history?
No family history. What should we do?
That scan is normal?
Okay.
Yeah.
So we went down the ataxia route. SCAR 1, 2, 3, 6, 12, 17 normal. Now that the DAT scan is normal, are you still thinking about MSA?
No.
No.
So when you have Parkinsonism, an MSA, then the MSA Parkinson and MSAP should be abnormal. So she had a normal DAT scan, so that's out.
No xanthoma.
No xanthoma. So we thought about Fragile X as a variant. She's a woman, but nevertheless, it was negative. Change your glasses, change your spectacles.
Vascular changes were there in the pons. To what extent those were there?
They were very, very mild.
No,
That's why they said
mild.
it's non-specific. Change your spectacles.
With such a normal MRI, you still think of fragile legs? No tremor?
Yeah, it can happen. Anyway, it was done. It was part of the panel. So
evolving overlap, some syndrome.
Change your spectacles. You are concentrating on the Parkinsonism ataxia.
So is there a sleep problem with her?
No.
Sleep is okay.
Family history is negative.
Yeah. Change your spectacles.
Audience has commented upon.
So at the moment, it was said to be, it was labeled as ILOCA, but we went on to do further genetic testing. We changed our spectacles and said, what if we look at her from the pyramidal point of view? She had 1 or 2 beats of clonus. She's got very brisk reflexes. So she's SPG7.
Oh.
And SPG7 now is now known to be the most important consideration in people with the so-called late onset cerebellar ataxias. So even though it's an SPG, it actually causes ataxia as the most common presentation. And she has SPG7, and we have now got a number of cases of SPG7 looking like MSAC, and it's not just us, other people have also described this as a important cause to remember in your patient. You remember in MSA, we are hunting for that little pyramidal sign. You're hunting for that little extensor. You're hunting for that little brisk reflex. When the pyramidal signs are shouting at you, then it's not MSA. It's change your glasses, think about the SPG. So a number of SPGs give you Parkinsonism. SPG 11 with thin corpus callosum, SPG 7, and others as well. So this was a lesson for us.
Very interesting, sir. Very nice. Yes.
Okay, next. So HPC, so this one I'm telling you about is a 28-year-old woman. She was a complicated case. She was born with 6 digits on each side, and the 6th digit was operated. She had delayed milestones. She had been resuscitated by her father when she was young because she was a blue baby. She had possible absence seizures. She had sleep apnea. severe mental disability, autistic, ADHD, and then later, recently, in the last 2 years, she developed mobility decline, leaning to one side, frontal disinhibition. You'll hear her now. She's crying. She's a challenging case to examine. She had been on neuroleptics for these behavioral problems. In the past, she had a CT at the age of 5, but nothing particular was reported. But we didn't actually have the CT scan, but the report was that there was nothing particular. She's currently on risperidone, epilim, trazodone, Capra. So let's just see this. Sorry about that, it's very noisy. So this is part of the syndrome.
Are you spastic?
Doesn't look very specific.
Hold on. You'll see more of the examination.
Shouting is a little peculiar, like a tick or what?
All this shouting is part of the syndrome.
Oh.
So is the Parkinsonism part of the syndrome or drugs related?
Well, we'll come to that.